Hello, good evening. I'm Dr. Mahesh, System Process Surgery. Today is shock. Hope you all had lunch. So we can, anyway, we are late by half an hour. We can start. Our topic today is shock. Shock is rather a boring topic, but it is indeed the most common cause of death in a surgical patient. In casualty, most common we are dealing with resuscitation and shock most often in surgical patient, and it is a leading cause of death of a surgical patient in emergency. Then coming to a definition, shock is a systemic state. It is defined as a state of low tissue perfusion that is inadequate for a normal cellular respiration. During shock, the cells will eventually shift from aerobic to anaerobic metabolism, which leads to accumulation of anaerobic metabolism products like lactic acid, and later it is a cycle which eventually progress to acidosis and causing cell death eventually. That is, the eventual cell death is the common endpoint of any shock patient if he or she is not resuscitated properly. Then the pathophysiology of shock can be at the cellular level, can be divided as occurring in a cellular level, in a microvascular level, and in a systemic level, including CVS, respiratory, renal, endocrine, and hemolytic. All this system will be eventually involved in the pathophysiology of shock. In the cellular level, the main issue is the anaerobic metabolism which ensues, because during shock there is inadequate supply of oxygen to the tissues, and the lack of oxygen will lead to anaerobic metabolism, and the final end product of an anaerobic metabolism is lactic acidosis and acidosis. Acidosis is a deadly thing as far as our homeostasis is concerned, and when it is not tackled, it will progress to the failure of sodium potassium pump, which is the main workforce of any cellular metabolism. So failure of sodium potassium pump leads to influx and efflux of many chemicals and mediators, and it leads to release of lysozymes and other organelles and causes cell lysis, and the cell lysis cause release of most of the intercellular components to the bloodstreams, which initiates a vicious cycle of problems. Next, at the microvascular level, during shock, the hypoxia causes a release of oxygen-free radicals and cytokines, which are toxic to the endothelium of blood vessels. And the endothelial injury causes the activation of immune and coagulation system. And once the coagulation systems are activated, it will lead to a state of coagulopathy, which leads to various other problems like DIC and multi-organ dysfunctions. And at the systemic level, the CVS, it causes cardiac level decreased shock, causes decreased. If it is hypovolemia, then the volume will be decreased, and there will be tachycardia, and sensitization of baroreceptors and chemoreceptors all leads to tachycardia and causes increase in and decrease in BP. Then once the arrhythmia can progress to cardiac failure. In renal system, shock causes decreased preload and decreased GFR and causes pre-renal failure initially and renal shutdown. Respiratory, once the acidosis is initiated, respiratory system is activated to wash out the carbon dioxide, and there will be tachypnea, and that tachypnea can eventually lead to this a state of respiratory alkalosis also. Once the compensatory mechanism fails, the acidosis prevails, and shock leads to a milieu of endocrine changes in the body. It causes release of renin-angiotensin, aldosterone, activation of renin-angiotensin aldosterone mechanism, which can lead to salt and water retention, which leads to hypertension. Then cortisols will be, adrenal system will be activated with the release of catecholamines, which leads to peripheral vasoconstriction, and steroids. Steroids will be released. Cortisol as an emergency hormone, cortisol will be released, which leads to suppressed immune response and hyperglycemia, and all these produce toxic effects. And the final, and all these effects, if not properly resuscitated, can eventually leads to failure of organs. That is the culmination endpoints of most of the shock. And the shock can be broadly classified as hypovolemic, which is the most of the shock you happen to see would be hypovolemic shock. Hypovolemic shock can be due to loss of blood, as in trauma during surgeries, and it can be due to loss of water from the body, which can occur during chronic diarrhea, dehydration. Then in hormonal disturbances like diabetic insipidus, everything can lead to hypovolemic shock, and it is the most common type of shock you happen to see. Then the cardiogenic shock. Cardiogenic shock occurs due to failure of heart and myocardial failure of pump, failure of cardiac pump. It can be due to arrhythmia, cardiomyopathy, or conduction abnormalities and whatnot. In obstructive causes of shock can be due to any obstruction to preload. Preload is the volume, that is preload of the heart, means it is the whatever volume of the heart that is there after diastole. And if there is obstructive shock, there will be a decrease in the diastolic volume of the heart. It can occur during cardiac tamponade, where the heart will be compromised, heart won't relax to accept the blood. Then it can occur during tension pneumothorax and trauma, hemothorax. Everything can cause obstructive type of shock. Then the other thing is the distributive. It is a kind where the blood will be there will be a peripheral state of peripheral vasodilatation, so that the blood will be pooled in the periphery of the body, rather than it doesn't comes to the heart or lungs for oxygenation. That kind of distributive shock, the characteristic feature of a distributive shock is a peripheral vasodilatation. It is the types which comes in distributive type is the septic shock, where there will be release of toxin by the microorganisms which causes extensive peripheral vasodilatation and pooling. It is the and in anaphylaxis also causes peripheral vasodilatation and distributive shock. Neurogenic shock is seen in trauma in spinal cord injuries, where in spinal cord injury, what happens is the loss of sympathetic tone. The sympathetic tone is necessary to maintain the vascular tone of the peripheral vasculature. So during sympathetic neurogenic shock and in spinal cord injury, the sympathetic tone of the vessels will be lost, and it causes peripheral pooling. The other one is the endocrine shock. The endocrine shock is seen in cases of extreme hypo or hyperthyroidism, and in adrenal failure like Addison's disease, where these hormones are necessary for the action, for the normal physiological action of sympathetic hormones to act, as in thyroid hormones and cortisol failure. Everything can cause endocrine type of shock. So these are the types of shock. Then coming to the severity. And the shock can be classified as compensated, where there will be only a mild lactic acidosis. The urine output will be normal. The patient's conscious level, pulse rate, BP, and respiratory rate, everything will be very normal. So that in the compensated state, body's compensatory mechanism will be enough to maintain the normal homeostasis. But in a mild shock, you can see there's the patient will become mildly anxious, and his pulse rate will start to mildly increase, and blood pressure, there also the blood pressure will be normal. Only the thing is that the patient will have a mild anxiety and a slightly increased pulse rate, and a slightly increased respiratory rate only. But his urine output and blood pressure, everything will be normal. In moderate, the patient will become more drowsy and his pulse rate will start to again increase. His BP will be falling. He will be showing features of hypertension, and the lactic acidosis level also will be increased. In severe shock, where the patient will be extremely anuria will be the symptom. In the moderate type of shock, urine output will be decreased. It will be less than 0.5 ml per kilogram per hour. But in anuria, it will be still very low, less than 0.3 or completely anuric. And the patient can be comatose, his respiration can be labored, and pulse rate will be increased, and the patient will be showing severe hypotension. Class coming to a topic which is of importance is the modes. As I have told, if a patient in shock is not properly resuscitated, the endpoint is modes. Modes is multi-organ dysfunction syndrome. It is characterized by failure of two or more of the end organs like lungs, kidney, and the hematological system or cardiac system. Any two organ if shows failure, features of failure, you can term it as a modes in a shock patient. In lungs, it can present as ARDS, and in kidney, it can present as decreased urine output and increased creatinine levels, and show features of acute kidney injury. In hematological failure is basically coagulopathy, where the patient will be showing features of intravascular coagulation and bleeding. In cardiac failure is is manifested by peripheral pooling and decreased BP and decreased cardiac output. And once the patient is in you are having a patient with shock. So the next step is the resuscitation of a shock patient. In the resuscitation pathway of every shock starts as airway, breathing, and then coming to the cardiovascular resuscitation. First, if a patient is brought to emergency with shock, first you have to maintain, according to the protocol, you have to take care of the airway. If the patient is not having proper airway patency, you may have to do his airway ventilation and assisted breathing techniques. Then if this breathing is not proper, he may need ventilatory support. And then coming to the circulatory resuscitation. Circulatory resuscitation first, when a patient is brought to the emergency, first you should have an initial assessment which can give a clue towards the cause of the shock. Because understanding the cause or type of the shock and the duration of shock is very important for the management and the recovery of the patient. Because if a patient is having a hypovolemic patient, initially needs fluid resuscitation, while if and the resuscitation protocol of a patient in sepsis is a little different from a patient from traumatic hemorrhagic shock. Anyway, if you are not having a clear idea of what is the cause of the shock, most often you have to take it as a hypovolemic shock, unless other obvious factors are not there. So you have to start with the fluid therapy. First, you have to secure a short wide bore cannula, because for resuscitation and IV fluid therapy, you prefer a peripheral line rather than a central line, which are long and narrow. Long and narrow lines like central venous catheters are not preferred for fluid therapy. It is preferred to give resuscitation through a peripheral wide bore cannula. And the fluids of choice are obviously crystalloids. Earlier, there was a teaching that if there was blood loss, you have to use colloids like hydroxyethyl starch and other colloid fluids. But now the standard is use only crystalloids, because the advantage of colloids are not that much compared to the disadvantages that they can offer. Because therefore, the crystalloids like ringer lactate or sodium normal saline is the fluid for resuscitation of choice. And dextrose and hypotonic, 5% dextrose and other hypotonic solutions are not preferred because it can cause for resuscitation in shock, because it does not improve intravascular volume. So initially you have to start giving patients crystalloids, and if blood is the main, if there is loss of blood is the ideal fluid for resuscitation if blood is available. If patient is having massive blood loss, initially also blood transfusion should be started. If there is massive blood loss and if there is no enough time for cross matching and availability of matched blood, you can use O negative blood for transfusion. So initially IV line should be secured and the patient should be started on crystalloid therapy, and the fluid of choice is either ringer lactate or sodium chloride. Then we have to assess the response of the patient for fluid. The assessment of response is usually done by a fluid challenge. Fluid challenge is rapid administration of 300 to 500 ml of crystalloid over 5 to 10 minutes, and we have to assess the changes in blood pressure, pulse rate, and venous and the urine output of the patient. So these three parameters are monitored after a fluid challenge. Fluid challenge means transfusing of 300 to 500 ml of saline over 5 to 10 minutes. And the patient can be categorized into responders, transient responders, and non-responders according to the fluid challenge. Responders are that the patient will have an increase in stabilization or improvement of these vital parameters, which will be maintained. And those will responders to fluid challenge will have only a minimal loss of vascular volume, which can be replenished with our fluid therapy. In transient responders, initially they will show improvement, but after 15 to 20 minutes, they start deteriorating. They will have a ongoing loss which cannot be maintained with the conservative approach. And the non-responders are that they will not show any response and they will be only worsening, and they will have a massive intravascular loss in the body. So they should be taken more care urgently. Then the patient may need support with the vasopressors. In patients with septic shock and all, they will have a failure of the vascular tone. So they may need vasopressor support like adrenaline and noradrenaline, vasopressin, etc. Because there the problem is sepsis and sepsis induced vasodilatation. That should be countered by using vasoactive substances like noradrenaline, adrenaline, or in some cases vasopressin. And in case of cardiac failure, cardiac shock where the pumping of the heart is inadequate, they need inotropic supports, especially dobutamine. Dobutamine is also called inodilator because it will cause inotropic effect. That is, it will cause the more effective contraction of the heart and it will decrease the peripheral resistance. And along with that, all these will be judiciously applied. What all things should be initially applied for what type of patient? It is a clinician's judgment. For a patient with a septic shock, the approach should be initial fluid therapy, and he may need vasopressor support. But for a patient with hemorrhage, the initial approach should be fluid resuscitation and immediate control of hemorrhage. For a patient with hypovolemia due to hemorrhage, initial fluid therapy should be given. He should be assessed and classified as responders or transient responders or non-responders. And if the response is poor, he should be initially taken without delay for control of hemorrhage. Obviously, surgery. And the hemorrhage can be evident or it can be non-evident, and it should be decided in the operation table. And coming to the monitoring of a patient in shock. Once if a patient is successfully resuscitated, somewhat successfully resuscitated, he should be monitored for further deterioration. And the minimum standards of any monitoring of shock includes ECG, pulse oximetry, BP, and urine output. ECG will give an idea about the cardiac status, and pulse oximetry gives of a pulmonary oxygenation status, and urine output is gives idea about the renal. And urine output is again the best indicator for the organ perfusion and the power resuscitation measures. And the additional modalities of monitoring include a central venous pressure monitoring. Central venous pressure monitoring is usually done ICUs by using specialized catheters called Swan-Ganz catheter. And 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 positive central venous pressure is that once after you give a fluid challenge, the central venous pressure should show an increase of pressure of 2 to 5 mm of mercury, 2 to 5 centimeters of pressure increase of 2 to 5 centimeters of water, and it should come come back to the previous level after 10 to 20 minutes. In a patient with ongoing bleeding and a failed resuscitation, this CVP will not show any improvement. And if the patient is having a cardiogenic shock or a obstructive shock, his CVP will be persistently elevated. Then the other modalities are invasive BP monitoring, then cardiac output monitoring. All these are invasive procedures, and evaluating the base deficit and mixed venous saturation. Here I want to stress a point of stress this base deficit and the serum lactate evaluation and mixed venous saturation. These two are important. In modern shock treatment, because there is a concept called the endpoints of a resuscitation. So in previously our targets of shock resuscitation was normalization of BP, pulse rate, and maintenance of urine output. But even if the patient is have returned to this normalcy of BP, pulse rate, and adequate urine output, he will again be in a state of occult shock, where the patient will have an increased lactate levels, and his mixed venous saturation will be in a deranged level. If a patient is in an occult shock, it is more dangerous that he can deteriorate in the next coming 12 hours. So in the modern practice, the endpoint of and the success of resuscitation depends on normalization of the base deficit and the normalization of the mixed venous saturation. So these are the various modalities of to assess the various organs perfusion. In systemic perfusion, the best indicators are base deficit and lactate levels and mixed venous oxygen saturation. The perfusion of gut and muscle, it is infrared spectroscopy. Gut, it is sublingual capnography and gut mucosal pH. Kidney, obviously urine output, and brain, it is patient's clear consciousness level. And this is the point I want to highlight, the endpoints of resuscitation. The concept of mixed venous saturation. The normal mixed venous saturation is of any person is between 50 to 70%. Once you assess a person's venous blood for oxygen saturation, it should be around 50 to 70%. In a patient with sepsis, his tissues will be compromised, so that the oxygen extraction from the blood will be compromised. So in a patient with sepsis, the mixed venous saturation will be always above 70%. And in a patient with hypovolemic shock, his tissues are okay, so it will be drawing more oxygen from the blood. So the venous oxygen saturation will be less than 50%. So mixed venous oxygen saturation will also give an idea of the type of the shock. And in a shock patient, if the mixed venous saturation is less than 70%, it means that he or she is going through both septic and hypovolemic. So the patient, our aim should be to resuscitate and make the patient with the venous oxygen saturation more than 70%. Then you have to correct for the sepsis. Next topic is hemorrhage. Hemorrhage, as surgical students, we have to deal with this hemorrhagic. Our aim in any emergency setting will be to control this hemorrhage. The hemorrhage itself is a vicious cycle, and this figure will, from Bailey, it will give an idea of the triad which can cause the problems with hemorrhage. In hemorrhage, trauma can cause hemorrhage and shock. In a shock, the patient will be in hypothermia, and hypothermia will be associated with acidemia. And in trauma, there will be release of many tissue enzymes, and there will be fibrinolysis and inflammation. All these will culminate in a condition called trauma-induced coagulopathy. Coagulopathy again increases hemorrhage, and shock continues. This will be a vicious cycle. Our aim as surgeons is to break this cycle and to bring back to the patient to his normal levels, rather than letting him go for a coagulopathy. And hemorrhage can be a revealed hemorrhage or a concealed hemorrhage. Revealed hemorrhage is obviously visible from a limb bleed, or it is visible from the inspection level itself. But in concealed hemorrhage, the hemorrhage is from the internal organs. It can be peritoneal bleed, it can be into the chest cavity, it can be into the cranium. And the other classification is primary hemorrhage. Primary hemorrhages are hemorrhages that occur primary during the insult of trauma or during surgery. But reactionary hemorrhage is that hemorrhage which can occur within 24 hours of the insult. And the secondary hemorrhage is that hemorrhage which occurs after 24 hours. And the hemorrhage can also be surgical hemorrhage, which can be controlled by surgical procedures. It can be from an internal organ, it can be from a blood vessel injury, which can be controlled by surgery. And non-surgical hemorrhage is from the generalized oozing occurs that occur in a patient with coagulopathy or bleeding dyscrasias, where there's a it will be a diffuse type of bleeding which cannot be controlled with surgical measures. And our management is identification of the site of hemorrhage. The site of hemorrhage can be identified by clinical examination, or if the patient is stable, we can do radiological investigations like FAST or CT. I hope you all know what is FAST. FAST is called focused assessment by ultrasound in trauma. That is the FAST, where a patient in trauma is initially assessed by using an ultrasound, where to assess for collection of fluid. Usually the ultrasound probes are placed in the right and left hypochondrium and in the pelvis and in the substernal window to assess for the pericardial fluid. So if there is any fluid in any of these areas, patient is considered to having some ongoing bleed and he may need surgical intervention. Or if the patient is relatively stable, we can do a CT which can better provide the site of bleeding if present. And hemorrhage control is obviously surgery. And no time should be wasted if the patient is in shock and if he's showing no improvement with the resuscitation. You should not waste time in doing investigations like CT and other investigation to assess the site of bleeding. He should be immediately taken to theater for hemorrhage control. And one of the newer concept in trauma management is the damage control resuscitation. Because in earlier time, in every surgeries, even in trauma, the aim was to maintain to return the patient to normalcy. If a patient is taken to surgery, taken for emergency laparotomy, if you happen to see a bowel injury, what we used to do was to resect and repair the bowel injury or repair any other solid organ injuries. Everything was done in a single stretch. But later people realized that if it will do more harm if you if you prolong the surgery for more time period, and if you do definitive repairs for a trauma patient who is already in a compromised state, it will do more harm than good. Then this brought out the concept of this damage control resuscitation. So in case of trauma, you only have to do things that is whatever necessary to maintain him alive and nothing other than that. So So you will be just debriding any bowel injury. You will just debride the bowel and bring it out as stoma, and you will just do a packing of a liver injury, and we will not go for any other heroic procedures in the immediate resuscitative surgery. And damage control surgery is a part of damage control resuscitation. In the initial presentation itself, our aim of a clinician should be to anticipate and treat the possible acute traumatic coagulopathy, any crushed muscles that can release enzymes, everything that should be debrided. The patient should be given thorough washing of the wound. Then they should be allowed permissive hypotension. Permissive hypotension is allowing BP adequate to maintain organ perfusion and not more than that. If the patient is having an internal solid organ injury, and if his BP is maintained more than 150, there is more chances for bleeding. So our aim is to maintain the BP adequate to maintain perfusion only, and not more than that. And avoiding excessive use of crystalloids and colloids, because if you, before arresting any bleeding, if you transfuse the patient with crystalloids and colloids, it will cause hemodilution, hypothermia, and it will aggravate the problems, and can cause coagulopathy. And next is the damage control surgery. Damage control surgery, as I have mentioned, is doing surgical process whatever necessary to maintain or to recover from the shock, and doing no other excessive reconstructive procedures, and nothing more than that. That is damage control surgery. It is the damage control concept was brought from military. In military, when a warship is injured from enemy missiles or so, they will do repair, or they will evacuate the ship to just enough to make the ship alive, so that it can be drawn to the dock for repair. So they won't attempt any major repairs in the middle of the sea. They will just make things adequate to make the ship float, and they will bring the ship to the dock for repair. So that was from the army we have taken the concept of damage control surgery. Hope there's a topic of shock is covered. And another topic supposed to take is the blood transfusion. First of all, indications of blood transfusion. As we all know, the common indication is acute blood loss. And in a patient with anemia, if you're taking the patient, an anemic patient, for surgery, we have to correct, and that also need transfusion. Then symptomatic chronic anemia patients also need transfusion. This is a table, and the another concept I want to tell you is that now previously everybody was so enthusiastic about transfusion. If the hemoglobin levels was less than 10, we were advised to transfuse patients with the blood. But now the concept has changed. Patient won't benefit from blood transfusion if his hemoglobin level is more than 6. It is the newer concept. So if you have to give transfusion only for a patient more than 6, that is up to 8, is 6 to 8 gram per deciliter patients are unlikely to benefit from a transfusion if he or she is not undergoing any surgery or not having any impending bleeding. So a patient with more than 8 gram hemoglobin have definitely no indication for transfusion in the absence of any other risk factors. So that this is a thing to be stressed. So a normal patient with a hemoglobin level less than 6 should only be advised. More than 6 won't benefit from transfusion. In a patient with 6 to 8 grams will benefit only if he is going for or he is undergoing any surgery, or if there is any possibility of bleeding. And a normal patient without any comorbidities won't benefit if his hemoglobin is more than 8. And blood transfusion does not. Blood transfusion includes the transfusion of both blood and blood products. Most people will have an idea that blood transfusion includes only transfusion of blood. Blood transfusion includes transfusion of both blood and blood products. So it includes the transfusion of whole blood. The whole blood contains RBCs, plasma proteins, protein factors, and all other blood proteins. And in packed RBCs, the RBCs will be more concentrated with red cells, and the hematocrit will be about 50 to 70%. And the packed RBC is stored in SAGM solution, and it is stored at 2 to 6 degrees up to 5 weeks. You can store a packed RBC. And fresh frozen plasma is rich in coagulation factors and proteins. It is the initial agent in a patient with coagulopathy to reverse the coagulopathy. It is stored in -40 to -50 degrees Celsius, and it can be stored up to 2 years. And another blood product is cryoprecipitate. It is again a supernatant of the fresh frozen plasma. It is rich in factor 8 and fibrinogen. It is transfused in patients with the factor 8 deficiency and all. And platelets you are transfusing in case of in thrombocytopenia, in case of dengue, and patients in on antiplatelets. All we have to transfuse platelets, and platelets are stored only for or less than 1 week at 2 to 5 degrees Celsius. Then prothrombin complex concentrates includes protein factors 2, 9, and 10. It is again most commonly used for reversal of warfarin-induced coagulopathy. Then the other one is an autologous blood transfusion. Blood transfusion can be autologous. It is mainly used in planned surgical patients where the patient's own blood is drawn approximately 3 weeks before surgery, and it is stored for use if need arises during surgery. It is a newer concept that there is a less risk for transmissible diseases, because blood transfusion has an inherent risk for transmissible infections. And these are blood groups I hope you all know. Then coming to transfusion reaction, the major transfusion reaction is ABO incompatibility, which is manifested as diffuse thrombosis and coagulopathy. Then the commonest transfusion reaction is the febrile transfusion reactions. These are again not no ABO incompatibility is involved in febrile transfusion reactions, and it can be due to a graft versus host reaction. It's also mentioned the antibodies in the host patient to the donor patient that can cause febrile transfusion reactions. Then another thing is these complications we can arise from a single transfusion. It can be hemolytic, ABO incompatibility, febrile transfusion reactions, allergic reactions, infections like HIV, HBsAg, syphilis, Creutzfeldt-Jakob disease. All these are infectious complications of blood transfusion. Then transfusion-related acute lung injury. It is an ARDS type of presentation, which is commonly seen after FFP transfusion. Then massive transfusion. What is massive transfusion? Massive blood transfusion is a transfusion of more than 10 units of blood within a few hours, or more than half of the patient's blood volume over 24 hours. This is the definition of massive transfusion. Massive transfusion can cause coagulopathy, then hypocalcemia, hypo or hyperkalemia, and iron overload. Then there are newer blood because of the cumbersome procedures involved in blood transfusions, like cross matching, assessment of infectious risk. There is a newer idea of blood substitutes, where the blood can be where a donor blood can be substituted with synthetic products. The synthetic products can be biomimetic or abiotic. Biomimetic products are usually hemoglobin based, and abiotic are perfluorocarbon based products. These are the recent advances and the future of blood transfusion. Okay. Thank you all.
No problem. We have another meeting here.
Okay.
Thank you, sir.
Okay, thank you.